Everyone's in, Dr. Hirsch.
Okay, great. All right. Sorry for the late start, everyone. The usual AV issues. So, okay. So this is, I think, the eighth AES Norse Institute Roundtable, something like that. So thank you for attending. There's food and drink. Drink is actually in the boxes, apparently. So in addition to coffee and water. Um, and we have people on Zoom who can now see and hear us. You okay? Okay, so here's our agenda. We built in a few minutes for setup and greetings and getting food, so we're not behind yet. Um, but you can see the rest of it. I'll tell you as we go. There's a couple thank yous. We want to thank UCB for helping to support this meeting. We also want to thank Cure for supporting it and for being the financial sponsor for the Norse Institute. To AES for allowing us to continue to have this in conjunction with meeting every year. And then, of course, to the people who've behind this meeting. So Nora Wong, as usual, did most of the legwork on setting everything up. And Mari Lynette Knight and Conrad back at Yale did all the other logistics. And Mari Lynette is helping to manage the Zoom right now. And Conrad did all the financial paperwork and other things. So thank you very much to everybody for helping make this happen. And with that, we're going to jump to our first talk, which is the Picori group. If the Picori folks come on up. So this is going to be a group presentation. And this is about our upcoming, just starting trial. You first, Maggie? Well, this is our agenda for what we're going to talk about for the Picori meeting. So Dr. Margaret Gopal will go first, then me, then Dr. Eschbach and Gopal, and then Dr. Wong. Okay, so we're going to start. There we go with Dr. Gopal. Take it away.
Thank you. Hi, everyone. We're certainly grateful that you can make it here today, and we appreciate your patience. So we'll jump right in. So just to tell you a little bit, some of you have been on our site kickoff meeting, but what is PCORI? And so essentially, they're one of the leading U.S. funder, and they're very patient-centric. What's unique about them is that they are independent. So for the folks in the US, they're not governmental. So they were not affected by any of the shutdowns or any of the things we experienced. And so we were able to pursue this funding mechanism. They're mainly funded through fees from private insurers. And they have a very unique place in the health research landscape. And that's because they focus mostly on patients and their outcomes as compared to other funders. And one of the big requirements with PCORI is that they want to make sure that you have a mechanism to access the patients, the caregivers, and stakeholders. And that's where the Norse Institute and Dr. Wong was very instrumental for this particular funding. And so the goal is to give voice to the patients and caregivers with the hope that those individuals will inform our decision and the care. And just to give you an example, when we wrote the letter of intent, some of you here were part of that process. And I remember we opened the summary with a quote from a patient and family. And it was very different for projects that we will do, like an NIH. It will not fit. And I remember Dr. Hirsch saying, whoa, we're opening with a quote from the families, but it's a different mechanism. And so we're grateful to Dr. Wong and the patient and the families that are on here on Zoom. I don't know how many are here, but we just want to say a big thank you. Dr. Hirsch?
Okay. Thank you very much. Oh yeah, so just to introduce our team. Basically, we're the 4 PIs for this. So I'm the overall PI, and then the 3 co-principal investigators are Dr. Gopal from Yale, Dr. Eschbach from University of Colorado, and Dr. Wong from the Norse Institute. We're also supported by the Yale Center for Analytical Sciences for all the statistical methodology issues and some data management, and the Yale Center for Clinical Investigation for Program Management. These are the sites. So we have 33 sites in total, 25 from the US, 8 international, including 2 from Canada. So these are the US sites listed, and many of you are here. And here are the international ones. Mostly in Europe. There's also Canada and also in Korea. We do have a DSMB, and Dr. Tom Bleck has agreed to chair that. I don't know if Tom's here. Usually makes it. And we have, you can see all the others. So all the others are real experts in Norse and fires from around the world, and mostly they were able to be on the DSMB because they're not a site, because they have to be independent of the trial. So that's why there's actually only one from the US on the DSMB. And we also have a steering committee. These people are allowed to be involved in the trial, but they helped with the design and they'll help with any issues along the way. You can see them listed here. These are mostly from the US, but some international representation. And the 4 of us sit on the steering committee as well. Okay, so why are we doing this trial? The short name of it is Combat Norse, which stands for Comparison Between Anakinra and Tocilizumab for Norse. So everyone knows what Norse is here, or you wouldn't be here. So we won't belabor that, except to point out that it does include just refractory status. It doesn't have to be super refractory, and it does include viral infections and autoimmune syndromes. They can present as Norse. In fact, anti-NMDA is always the #1 etiology for cases that are eventually figured out. It's a 5-year, $15.7 million international trial for ages 2 and older, and we're hoping to begin enrollment in mid-2026. And the purpose is to randomize patients by day 7 with cryptogenic Norse to anakinra or tocilizumab. And basically, other than that, your care is exactly the same. We just decide which one of those 2 you're going to give at day 7. And then we have all kinds of outcome measures that the other folks will talk about. So why are we doing this trial? It's really because of this decision you have to make around day 7 where for cryptogenic Norse, where you need to pick anakinra or tocilizumab, and there's no way to pick which one right now. So no one has any clue, which gives us equipoise and a good chance for a comparative effectiveness trial. So we're aiming for 438 participants, 310 in a randomized cohort, and for people who cannot be randomized for whatever reason, whether it's too late or they just decline, then we will put them in an observational cohort. You can see the dates there. We actually only have a little under 3 years to enroll patients because we have to give them a year of follow-up and 6 months for analysis and writing up, all within that 5-year time frame. And then we have the very important Patient and Family Advisory Board you'll hear more about in a minute. I told you about the 2 cohorts, a randomized and observational one. One important point is we are trying to do biosampling as we've been doing, but that is not funded by PCORI. So anything we do with that has to be completely separate funding for the personnel time as well as for actually storing, shipping, biobanking, et cetera. But we do hope to do all those. If any of you have trials you want to do using the PCORI population, please let us know and let us know soon. We're very eager to get those funded. We'll help with grant writing and all of that because we do want to be able to keep doing everything we've been doing in the biobank. There will also be semi-structured interviews from the University of Colorado with Dr. Eschbach is running that. That's for the qualitative component in about 125 patients or their caregivers. Primary study aims in the randomized arm is to evaluate the effectiveness of anakinra compared to tocilizumab for cryptogenic Norse. And the second aim, mostly from the observational arm, is to look at the effect of the timing of second-line immunotherapy. This is the study protocol. It's actually recommended dosing. It's not required that you stick to it because it's very, again, patient-centered and clinical team-centered. So if you want to do it some other way or think there's a better way for your patient, you can. But this is going to be the suggested dosing. It is IV, 10 mg per kg per day for anakinra, and tocilizumab is weight-based with just 2 categories. And then for biosampling, you'll see the timing that we're doing. Will be a discussion later about timing of biosampling. And the biobanking we will continue to do at Yale as we are doing now in the biorepository, which I'll give you an update on a little later. Okay, on to outcomes. I think you're doing the primary outcome.
Okay, so when we thought about our outcomes, again, going back to PCORI being very patient-centric, we actually consulted with our patients and family on what's the best scale that would suit the study and also their goals. And so the Glasgow Outcome Scale extended version was selected. And so it's the functional status will be measured by this scale, and it's at 12 months and it's post-treatment, and it will be centralized at Yale. And so it would be done by a blinded investigator. So none of the sites will be involved. It would just be centrally done. We also decided on a futility analysis that will be conducted once we have 50% of the randomized patients who have the 6-month blinded GOSI completed. And one of the things about the GOSI, many of you are probably familiar with it, but for those that are not, it's validated for both adults and pediatrics, so it's suitable for our study. Has high reliability, and we also have good experience with the current Yale Biorepository Multi-Center that we have been using that, and many of you are part of that, so you are familiar with it. But like I said, the more important element was that this was something we ran by the patients and families, and they found that it supports their goals and what they would like to see. And I think we have a little bit of a snippet of what it looks like. Again, many of you might be familiar, but the Glasgow scale basically is 8 steps, and it has step by step. So it goes from death to full recovery of functional, and this is usually scored on. You don't need to be bothered about the scoring. We'll have training on that. But so for scoring 1 and 2, that goes from death to kind of a vegetative state. And 3 and 4, we have a spectrum of lower to upper severe disability. 5 and 6, you have lower moderate disability and then upper level. And then the final is 7 and 8, which is a range of good recovery to upper level of good recovery. So for those that are part of the study, we will provide more training. So thank you, and I think Dr. Eschbach will now go into more of the other outcomes that we're doing.
Right. So yeah, this is the primary outcome measure as we discussed. We will also look at additional outcomes. So obviously thinking about some of the other things for our secondary outcomes, when does status resolve, how long are patients in the hospital, adverse events attributed to the anakinra tocilizumab, as well as future development of epilepsy. And then we have a treatment success outcome as a secondary outcome, which is a combination of the lack of a need for an additional immunomodulatory treatment, as well as the Glasgow Outcome Scale extended. And I do want to highlight, as we get to the exploratory outcomes, I think we did run the primary outcome by our patients and families, and I think as much as that's in support, I think it's acknowledged that that captures just kind of one aspect and very broadly. And so we have a lot of exploratory outcomes because I think the experience for survivors, there's a lot more that goes into it. We want to make sure to capture that as well. And so we'll be looking at some of the measures listed here in terms of the impact of seizures with the seizure-related impact assessment scale. We're going to be looking at patient and caregiver reported outcomes. I'll go more into those on the next slide. A symptom checklist. This was really led by our patient family advisory board, where they are noticing and experiencing symptoms that can be very broad and affect many different organ systems. And so this is how we'll be able to capture some of those. And then also the interviews as we discussed. So our patient and caregiver reported outcomes. So there's a lot that we're going to be asking people to do at 12 months, and we acknowledge that. Here's the domains that we're going to cover. From a patient standpoint, it's patient reported, but if the patient is not able to complete the scales, it'll be done by a proxy or a parent. And so that's looking at quality of life, behavioral, mental health, cognition, communication, social and relationships. And then even though we're doing that symptom checklist, there's also some validated measures for looking at non-neurologic symptoms, so fatigue, sleep, and pain as well. And then also acknowledging the impact on caregivers. And so we will have 2 outcome scales that are specific to caregiver quality of life and caregiver burden. All right. And then again, the interviews, as we mentioned, which will actually be done on 125 patients. It'll be split across the groups. And then we'll also be doing interviews with patients and families families and caregivers of patients who did not survive as well. Yeah. All right. And then Nora's going to.
I think what especially Kristen and I have discovered that working with patients and families as colleagues, as opposed to with a doctor-patient relationship, it reveals how much we each don't know about the others. Okay. Okay, I will start again. Working with patients and families as colleagues, as opposed to a doctor-patient relationship, reveals how much we each do not know about the other's experience. So, for example, investigators are focused on established, validated measures, enrollment, and missing data. Our patients and families have pointed out that some of our outcome variables are not a priority for them. They don't resonate with their experience, or that it's impossible for them to fill out some of the forms or complete the items because the day-to-day experience is so variable. So in terms of consent forms, as one parent points out, the consent form should not be the first time the family is informed that they have Norse, or the first time they are informed about the outcomes. So that tells you that the previous experience of the communication, the history of interactions between the patients and families and the doctors will influence the enrollment and the missing data of our studies. Engagement with our patients and families has been an eye-opening and humbling experience. And we've learned in our short time with that we've been acting together formally, we've learned a great deal from them. And I think that we are all awed and grateful that our patients and families are willing to go back to the most terrible time, life-altering period in their lives, to work with us in detail and help us do this research that will help someone else. So for those of you who are wanting to improve patient and family engagement, I think the first step is simply to listen to them and to be open to when they say something unexpected, something that has not been published, that you take that as a new data point and to add that to what we are all learning about Norse.
Thank you. I think you covered that. Okay, that's it. We have a few minutes for questions about PCORI at all. So let's open it up to everybody. There's microphones on the stands, and there's 1 or 2 roaming around. But please only speak with a microphone so people on Zoom can hear you. Go ahead, Rima.
Thanks.
Oh, and say who you are because people
Hello.
can't see you on Zoom.
So, Rima Nabout from Paris, pediatric neurologist. I was wondering about 2 points, and without going into much details, what are you expecting as difference and granularity with your primary endpoint to go in such numbers? I mean,
Yeah,
what is
1 point on the Gaussian
1
scale
point.
is what counts as
1 point?
change.
So, I'm sorry?
Yes, 1 point on the Glasgow outcome scale.
1 point. Okay, and it will need such a number of patients.
Yeah, obviously there's very little data on
Okay. No.
to
It was
define that,
just,
but yes, that's what
it
that's
was
what we
just,
came up with the
thank you.
statisticians.
Hello, Gerhard Kluger, pediatric epidemiologist working in the team with Eugen Trinker in Salzburg and Andreas von Baalen in Kiel. We want to bring out in your study a group of children which we call atypical fires because of a mutation in DNM1L and IQSEC2. So this, we have the impression the outcome is different and the treatment is different, but we want to include in your study, and we would like to invite everybody to send us patients. If you have seen patients with atypical fires with these mutations, we are happy if you include those patients.
Say the mutation again.
IQSEC2 and DNM1L.
DNM1L. Right. I think we have one patient with that in our repository right now, but only one.
Anna Maria Vezzani. I think it's a great opportunity for collecting biospecimens in this study, probably a unique opportunity. I know that it's not sponsored, but can you predict if there will be some, possibility of really exploiting this prospective clinical study for biospecimen collection? Do you think that the people that are contributing with patients will be able to collect specimens at their own expenses, or it's very difficult?
Yeah. So in the US, doing research on your own expense does not work. Somehow it works better in Europe. But we're getting funding. We have a little bit already. So yes, we are planning on it, but we need to get a lot more funding to be able to do it for all the patients. But yes, that is certainly the
So, yeah,
plan, is to
for a-
keep bios.
Larry and team, Toby Lodenkemper, Boston Children's Hospital. Congratulations on the Sentinel trial. How can we help you save the EEGs and the MRIs to the clinical biosamples as well? I think there's a tremendous opportunity if you're prospectively collecting the data to at least save these specimens. Is that planned, or do you need an add-on grant for that?
That's kind of a similar answer to the biosampling, in that it's not part of the primary PCORI trial, but we do hope to save and gather EEGs and MRIs. But again, that's going to take additional funding, not as much as the biosampling, but that's not covered by the parent trial. So all the effort and time doing on that cannot be paid for by the PCORI trial. I know it sounds like a lot of money, $15 million, but you take 33 centers in 5 years and all the supporting staff, it ends up being very little money, as many of you have seen. And we are planning on having at least about a half time of a research assistant at every single site to do daily screening, so we don't miss patients, and then we can enroll them by day 7. So, so all those things we do plan to do. PCORI doesn't fund the biosampling or all those kinds of analyses, but they do allow them. They don't mind it. In fact, they're letting us put it in the same consent form, but they won't pay for it, and we have to keep very careful track to make sure we're not using PCORI money for that. All right, we're right on time. Move to our next topic, but we'll be around after for other questions about PCORI. Okay, so next we're going to hear about the Arisen study, another already funded early stage trial. Dr. Stredny and Gambale will be presenting on this one. Come on up.
Thanks so much. So we'll start by talking about Arisen, which stands for Autoimmunity, Rasmussen's, Inflammation, and Status Epilepticus Research Network. We'll do an overview and also talk about some initial answers to some of the questions that you have, and then look to future grant opportunities. So Arisen is recently funded as part of the Rare Disease Clinical Research Network through the NIH U54 grant mechanism, funded via NCATS and other institutions, in our case, NICHD. It's a 5-year grant with the option to renew for 2 additional 5-year cycles for potential funding for up to 15 years. And so Arisen will combine two existing consortia and expand upon them and their existing aims. So Grace and I, for the last several years, have run a consortium that we call CONNECT, or Conquering Neuroinflammation and Epilepsies Consortium, that's currently funded via PERF. And of course, the other fund that we're very familiar with is the Norse Institute Prospective Observational Study in the Biorepository. And so Arisen will combine these two for future enrollment and study. And so diseases included will be autoimmune encephalitis, both seropositive and seronegative cases, Rasmussen syndrome, and Norse, including cases of fires. Grace is one of the MPIs, along with Christy Murray at Emory and Choa, and several of us are co-investigators, including Larry and myself. This will include at least 20 sites with the potential to expand to more over the 5 years, including many of you, and at least 10 of these sites will initially overlap with the projected PCORI sites as well. And so this is a very large grant with lots of different aims, and it's actually split into 3 different projects, which we'll just very briefly overview so you get a sense of what we'll be up to. Project 1 is main focus is clinical phenotyping, so establishing ongoing prospective longitudinal cohorts of these patients to understand the history of the disease with a focus on long-term cognitive outcomes in each of the syndromes. And then Project 2 will focus on improving outcome measures for clinical trial readiness for future clinical trials. So looking at functional patient and caregiver reported outcomes, looking at novel ones and comparing them to those that are commonly employed in current trials or in prior studies, and then also comparing and contrasting this with more extensive neuropsychological batteries. And then finally, Project 3 focuses on early biomarker discovery, so looking for immunologic as well as novel autoantibodies that will help us improve timeliness of diagnosis as well as guide therapeutic interventions. And some initial aims here are cytokine and cellular processes, understanding CSF host transcriptomic profiles, as well as looking for novel autoantibodies. I'll turn it over to Grace.
Hi, everybody. It's nice to meet you all. I'm Grace Gambale. I'm one of the pediatric neurologists. I'm a neuroimmunologist by training, so not an epileptologist whatsoever, but I'm very excited to be working on this project. I'm actually based out of here at Emory here in Atlanta. So this is going to be the timeline for when we recruit patients. So first we'll identify a patient, obviously obtain consent in a proper manner after establishing relationships and making sure that they know about their diagnosis and outcomes before meeting the study team. And then the registry is going to include lots of different forms. It's really important for us to look at patient caregiver impacts of their diseases. So we have patient and caregiver facing forms, clinician forms, and as part of this work, we're actually creating an EEG biorepository, MRI repository, and clinical samples biorepository too. And then all of this is going to be in a central database. So the mechanism for this U54 rare disease grant is to encourage rare disease research not only amongst the actual consortia itself, but outside. And so the NIH really finds it a priority to share data, samples, all of the repository with other investigators. So even if you're not directly a part of it, part of the Arisen consortium, there's going to be opportunities to have access to the data, access to the samples, access to the EEGs and MRIs. So our biorepository includes serum, plasma, peripheral blood, mononuclear cells. We're also collecting DNA, RNA, and CSF. We have had ongoing discussions about collecting additional samples, including nasopharyngeal swabs, stool, urine, and other tissues, but that's an ongoing discussion because even though this is also a very large grant, it's not able to cover all of these specimens. As part of this, like Coral mentioned, we have 3 big projects that are ongoing that we have proposed to the NIH that we are going to aim. And as part of this, this grant mechanism, we're actually given funding to give out to other investigators to leverage our registry for their research. So one of the cores is called the pilot core. So we're actually offering pilot grants. That's actually going to be led by Dr. Hirsch and myself. And so we're going to offer pilot grant opportunities for people to apply for funding and then also to leverage our registry for their work. And the other piece is really encouraging our junior investigators, our trainees, to go into rare disease research. So another aspect of this registry of our consortium is the Career Enhancement Core, which is led by Drs. Heilman, Clardy, and Murray, and they're going to help with training our next generation of researchers, to encourage our junior investigators, to provide them the resources, not only funding, we have a grant opportunity that I'll show you in the next slide, but also training opportunities, collaboration and mentoring opportunities within our network. So our plan is that early 2026, we're going to actually publish our funding opportunities. So I encourage all of you to be thinking about these projects, think about applying for them. And then as part of the Career Enhancement Core, in addition to the funding that we're going to offer to all of the investigators, is monthly workshops talking about all the issues, all the challenges that we face in rare disease research. We're also going to have a yearly half-day mentoring session, especially for our junior faculty and our trainees, pairing with mentors and, again, the early career enhancement grants. So as part of this U54 mechanism, kind of in line with the PCORI, our patient advocacy groups are a key member, a part of this. They're not just somebody we list and we say, okay, we're going to ask you to help with recruitment, whatever. They're actually key stakeholders at the table as we're designing our studies, as we talk about what data we're collecting, what outcomes we are looking at. They're an integral member of the scientific and study team. And so we have partnered with 5 patient advocacy groups. If you know of others, we'd be happy to partner with others. But we have the Sumire Foundation, the Autoimmune Encephalitis Alliance, the National Autoimmune Encephalitis Society, of course, the Norse Institute, and then the RA Children's or Rasmussen's Encephalitis Children's Project. So next steps for Arisen, we're going to start onboarding 5 to 10 sites at the end of year 1. We are in the process of getting all of our protocols, our RIB protocols, and our data collection forms in place. And then we're going to continue to enroll and include additional sites by years 2 and 3, but hopefully by year 3, we'll include additional sites. There are mechanisms that even if you are not currently a site for Arisen, that there are ways that we would be able to include additional sites depending on funding. And then for those of you who are part of the PCORI Combat Norse, for those sites who are a part of both Arisen and the PCORI Combat Norse, there's ability to co-enroll for both of those studies. So here is a QR code if you are interested in being on our listserv for when we do publish our funding and grant opportunities. You can sign up here. You can also feel free to reach out to Coral, Nora, or Larry, or myself, and we can always add you to the list. We do have a website that's not totally up and running yet. There's some very skeletal information things on there, but in the next 6 to 12 months, we'll have a running website discussing all of our patient advocacy groups, all of our activities, how to access our data, for example, and the funding opportunities. So thank you for your time. Let me see in terms of, I think we have a few minutes for questions. So any questions for us about the grants or Arisen? Mm-hmm.
Just thinking about the outcomes that I just discussed and how many we're asking patients and families to do for the PCORI study, can you share at what time points you guys are assessing outcomes and a little bit more about them, just thinking about the burden for patients and families?
Yes.
Outcome measures.
Yeah. So the question is about looking at what kinds of outcomes we're looking at and the time points for them. This is a struggle, and as we develop these clinical registries, because we want to capture as much data as possible because we don't want to miss anything. At the same time, knowing feasibility is also really key, especially for our patients, families, and for our clinicians who are helping to fill out this form, because unfortunately, I'm not paying anybody enough money to do this work. That's an ongoing process that we are looking at with our IRBs. As part of this Arisen network, we, like Coral mentioned, we are combining Connect and the Norse Institute for the Biorepository Prospective Study that's already been ongoing. We're also collaborating with the Extinguished Trial, for those of you who are part of the Extinguished Trial, which is the U01 grant through the NeuroNext group funding for NMDA receptor encephalitis. We're also trying to partner with them and making sure we're collecting data in parallel, but understanding we've all looked at slightly different outcome measures and at slightly different time points. So we're trying to sort of harmonize that.
Congrats again, Grace and Coral. My question is about whether you have a vision for including disease control cohorts, particularly for biomarker discovery, and if so, what that vision is.
Yeah, that's a good question. So the question is about looking at controls. So one thing about this study, and one of the reasons why we included autoimmune encephalitis plus Rasmussen plus Norse is that there is some overlap in presentation and symptoms and potentially some overlapping inflammatory pathways. We also know these are different diseases, so there's going to be differences. So one of the things that we are looking at is that we could actually do comparative studies. So there are going to be control groups of different neuroinflammatory type things. The other piece is that we don't have funding for looking at controls ourselves. There are some sites who are able to collect biospecimens and data for controls within those institutions. And so that's where that comes with. But one of the things about theorism, like Coral mentioned, the opportunity is for up to 15 years of funding through the U54 mechanism. But the idea after that is that the consortium is going to thrive on its own, thrive independently. And so the goal is that we have so many aspects that we have to look at, that we need to look at in these diseases that we haven't even touched upon. I mentioned the EEG and MRI repository. We're not doing anything with that data, but the NIH recognized the importance of collecting that because these are rare diseases. So we're going to collect this repository, put it all together. Excuse me. And then for those of you who are interested in applying for additional grants to support that, applying for additional grants to help support some of the control specimens and all of that, we'd be happy to collaborate with you. Yes.
Grace, I'll read it.
Okay.
Okay, this is from Marios Kaliakatsos from Gosh. Are you planning to include European UL centers? We have just had a PhD started on Rasmussen, and at Gosh, we have one of the largest cohorts worldwide. But in these disorders, I think only international collaboration can lead to meaningful outcomes.
I agree with that. And so our initial intent was to include some international sites. But as you know, the administration had changed some of their priorities and what was allowed in terms of international funding. Initially, we were told no international sites were allowed whatsoever. But now it sounds like the NIH is changing it where they are considering some international sites that can be included. My understanding is they're exploring how that funding would be transferred. But happy to collaborate at the very least. We can share our clinical research forms. Actually, once we get them established, they're going to be shared publicly. There'll be a public link to look at those forms, so at least we can collect data in parallel and then do comparative studies. But I wholeheartedly agree, the international collaboration is really key for this.
Very much. Do it again. Oh, I'll take it. There. Okay. Thank you very much. So as you can see, we already have one source for getting some funding for biosampling, at least in the 10 centers that overlap. So Arisen was the first opportunity that arose. Yes, pun intended. Okay, moving on. We're next is Dr. Nicholas Gaspard. We'll talk about the Sense Registry. Okay. Oh, not.
So people should, I don't care if I don't see my slide, but people should
No,
see my
that's
slide.
being- Hmm. Not
Stuck on the wrong slide. It's still on it.
we're advancing, but that's not. Maybe there's other two iterations of it or something.
The new one, right? Is that the actual?
To present the Sense2 registry. So it's Sense2 because it's actually a sequel to the Sense registry, which was launched 10 years ago. I'm looking at Andrea because he was one of the mastermind behind 15 years ago, recruited 1,000 patients, a bit over 1,000 status epilepticus cases, and led to a bunch of very high impact publications. So following up on the Sense registry, people in the critical care and the epilepsy sections of the European Academy of Neurology, so it would be a good idea to keep going with another registry on a larger scale. So that's where the Sense2 registry came to life. So it's really it's still a growing entity. It's not finalized yet, as you will see. We are getting new centers every month. The idea was to have a broad international multi-center network in Europe to represent the diversity of status epilepticus, of local practices. Europe is very heterogeneous when it comes to access to healthcare. So we wanted to have something that would represent the breadth of Europe and availability of the resources in terms of anti-seizure medication, anesthetic drugs, access to EEG monitoring. As you probably know, the US is a very lucky place when it comes to access to EEG monitoring for status epilepticus. Not many countries in Europe can afford to do that. Same thing, access to ICU beds is sometimes limited. So we wanted to have a broad overview of what was going on in Europe, to collect large and detailed data sets that would allow natural history studies, causal inference studies, comparative effectiveness studies, and also, thanks to its large scale, hopefully give enough data to learn more about status epilepticus in rare conditions, including Norse. And finally, the idea of the registry, which is at the moment totally not funded, so it runs only on free time or protected research time of the investigators. The idea was it would be a first step towards becoming a funded platform to have a biorepository, and it's actually almost there for the biorepository, but also to become a status epilepticus trial network. So the way it works, it's prospective data collection and sharing. It's a consortium. We have consortium data sharing agreement. All the data is centralized in a REDCap database. We in Brussels, we take care of the logistics. We host the REDCap database and take care of the paperwork and things like that for the centers. There's a steering committee that's composed of actually the first 10 centers who made the registry. And around the steering committee, there will be task forces. And I will come to that in a moment. It's a very democratic way of doing things. Anyone who's part of a consortium has access to the data, can propose research studies, and the research studies are vetted in the steering committee, and everybody gives data, actually gets the data from all the other centers to run his or our studies. There are two ways to enter the registry. Either you enter all consecutive status epilepticus that come to your hospital, or you focus on refractory status epilepticus admitted to the ICU. That's because part of the investigators are epilepsy specialists, so they see most status epilepticus cases, and some investigators are intensive care physicians or neurointensive care physicians, and of course, these investigators only have access to the case admitted to their ICU. You can do adults, you can do kids above 2 years old, you can do both. We mostly have adult centers at the moment. That's the registry at the moment. We cover 33 centers in 16 European countries. As I said, mostly adult centers. So if anyone is here, is in Europe and does kids, please just reach out to me, and we'd be more than happy to get you in the registry. As I was saying, it's still a growing living thing. So centers are at different stages of the process of getting in terms of IRB approval, in terms of data sharing consortium agreement. So 19 of these centers are active, meaning that they have IRB approval and can start entering data in the registry. The other ones are still working on their IRB approval. You can't read probably the list of the names, but that's all the investigators and centers that are at some stage of being part of the registry. The first 10 on the top are the centers that make up the steering committee. The way it's organized, we have the steering committee, and then around the steering committee, there will be soon task forces run by some people that are actually, some of them are in the audience or on Zoom at the moment. It sounds very much like the Arisen project, so we definitely want to have biorepository for biosamples, imaging data, and EEG, and there's also a task force for long-term outcomes. And these are the names of the investigators who will take care of leading these task forces. The study protocol has been published a couple of years ago in BMC Open, BMC Neurology Open. So you can look it up if you want more details about the data we're collecting. As I was saying, there's a core data set of clinical data that everyone agreed to collect prospectively. And there will be additional data collection through imaging, EEG, biosamples when feasible, and long-term outcomes data. Depending on the country, on the centers, we don't need informed consent. So access, for instance, to long-term outcome data varies from one center to another. Europe is kind of complicated when it comes to and actually very heterogeneous when it comes to the need to have informed consent to have access to long-term functional data. For instance, some countries, some centers do allow collection of long-term outcome data without any kind of informed consent. Some require informed consent, so there is variability there, and we will try to work out a solution so that everyone or most centers can collect those data. The core data sets includes, of course, demographics, outcomes, statistical related variables, very, very typical data that you would collect in this situation. We try to align as much as possible with existing registry, especially the Norse registry and the data set that's collected in the Norse biorepository. At some point, we would like, of course, to link the two data sets. This could be an excellent data set, for instance, to provide historical control against the active arms of the PCORI trial. So you have demographics data, you have comorbidities, statistical variables, semiology, etiology, and so on. There are treatment related variables, including the use of immune therapies, very minimal data on life support therapy like intubation, ventilation, and requirement for ICU and duration of ICU stay. At the moment, so the target enrollment at the moment we launched the registry was supposedly 3,000 cases over 5 years. I can't tell you exactly when we started collecting data because centers kind of started at different time points depending on the time they got early approval. I think the first center to collect data was us, and we started collecting last year. So it's been over 1 year in Brussels, and most of the centers actually started earlier this year. And as of yesterday, we had 816 cases in the registry, including, I just checked it up this morning, 54 cases of Norse and fires. Not all of them are cryptogenic, I think, but 54 Norse and fires cases. So, that's only a few months of data collection by roughly half of the centers that will be part of the registry at the moment. So so that's it. If you have any questions, I'll be happy to take them. Right. So if you're in Europe, you want to be part of the consortium, just send me an email.
Awesome. Thank you. That enrollment is very impressive and fast. Okay. Next. Oh, that's me. But the update on the Yale Norse Fires Biorepository, I'll go fairly quickly to make up a few minutes that we lost for technical issues. And there's some thanks you see there for people who helped put all these numbers together for the update. And they're all updated as of a week ago or so. So right now we have in our prospective, very detailed multi-center studies supported by the Critical Care EEG Monitoring Research Consortium. We have 95 acute cases of Norse. In the new open biorepository from anywhere else in the world, we have 71 cases for 166 acute Norse cases. And you can see where they're from below, and it includes 16 countries, as you see in the yellow there. And then we do have some chronic cases and some controls at much smaller numbers. These are the numbers enrolled per year. 2024 was the most. 2025 is 28 and counting, so still second most and accruing fairly rapidly. And these are some of the numbers in the acute cases. Median age is 26. We now have 48 pediatric cases, so that's catching up to the adults. Among the acute Norse cases, 67% qualify as fires as well. In adults, that was 60%. In children, that's 85% that qualified as fires, and that was a statistically significant difference. You see the presenting seizure types on the right there. So a little bit of data about cases that have known etiology or don't. So overall, 13% have had a known etiology identified, including 9 fires cases. So you can see that the first column up there in the orange is Norse with known etiology. And that is more likely to occur if in the non-fires cases, where it's 29% compared to fires where it's 8%. But if you compare adult and children overall, it's actually the same. So the difference is whether fires or not, and children more often have fires. And then you can see the known etiologies listed down at the bottom. The first few are autoimmune. Then there's a few genetic ones. And then on the right are the infectious ones. And then, see if I can. It won't let me close that little black box. Sorry. The causes for fire patients, you see listed there. We can move it. Okay, and I put whether they were adult or peds as well. So it's kind of interesting that 2 pediatric MOGAD patients presented as fires, the febrile infection first. Okay, this is just some other data about the patients. They're very sick. Status duration, a median of 18 days, ICU 35 days. 21% patients did not survive the hospitalizations, still a very high number. And in long-term outcome, at 1 year, people who had at least a year of outcome, 67% had at least one unprovoked seizure and qualified as epilepsy. That means 1/3 did not. As far as functional outcome, you see hospital discharge on the left. And so this is the Gaussy scale, and it's up in the left for those of you who forget it. And then, so on the upper right, you see the 12-month outcome. So first is with everyone included, and the second one in the upper right is just those who survived. And what you can see is by 12 months in the survivors, you start to see a much higher rate of pretty good outcomes. So 7 and 8 combined is 37%. And then at 2 years, if you look at survivors only, that gets even better, or half of the patients reach the either mild disability or full recovery. But if you took all comers from the beginning, again, there's still that large number that didn't survive the initial illness. Okay, these are the number of samples that we received, and the last column is the ones that are still available, including some tissue over on the right. The bottom line is we still have lots of samples for you. For anyone who wants to do research, please give us your applications. We have a quarterly steering committee meeting to give those out. This is just some of the numbers in the chronic phase or post-Norse epilepsy. These are some of the controls we have. And I just did want to mention some financial realities. So we do now have to pay biobanking fees that we didn't used to have. Shipping fees have gone up significantly. We do not have indefinite long-term infrastructure funding, so we do need support for the biobank. So we are asking everyone who writes a grant that's going to use this to not only say you want our samples, but to include biobanking fees in the budget. So it's somewhere around $200 a sample covers what we need to do. So everyone writing grants, we're going to encourage you to make sure that's in there. And then we may need to start actually charging for use of the samples. So far, we have not, and we're not making that change right now, but that's a possibility depending on our level of funding. These are just some of the recent applications that were approved and for which we provided samples. Give you a second to scan them. I'm not going to go over them, but they're from all over the world and all different types of studies. And these were other ones that just use clinical data and not necessarily, no samples, just data. Also quite a variety of topics. And these are some of our recent, just the publications from 2025. You see one on cognitive outcomes, one on quality of life, one where CBCs, simple CBCs could predict outcome. We have ones about the microbiome, which you're about to hear more of. One looking at subclusters of inflammatory profiles using the 96-plex, showing there's at least 3 different types of inflammatory profiles, which have implications for possible treatment. And then a review of the intrathecal dexamethasone results from our biorepository. Another long-term outcome study, and one comparing fires to non-fires and looking at different ages as well. So that's it. I just wanted to thank all our collaborators, most of whom are the people in this room, and to everyone who shared samples and data with us, and a special thanks to all the patients and families. I know a few of them are on Zoom. And with that, I will stop and take questions. Any questions about the biorepository? Nor anything in the chat? Okay. There was one question in the chat earlier about will the sites that are co-enrolled in Arisen and in PCORI, will that take care of gathering biosamples for those sites and pay for it? And the answer is yes. Oh, I'm frozen. All right. Moving on, we have a discussion on timing of biospecimen collection and immunotherapy with several presenters. You can all come up, or one of you can come up, or it's all yours.
So good afternoon, everyone. So I have the pleasure to present the slide today on behalf of Anna Maria, Stefano, and Vincent and here who are on Zoom. So this is a project we discussed since like a long time regarding the timing of biospecimen collection and specifically regarding immunotherapy. And if we went to this project, it's because we had many times the question about when the sample have been collected, when we presented results for cytokine or for brain injury biomarkers, and notably if it was before or after immunotherapy. So just a brief background. So what published like in the past years, so we found different cytokine profiles in the acute phase for patients with cryptogenic Norse. And based on that, we suggested different type of immunotherapies. We also found that patients who had the most impaired cytokine profile, notably for the innate immunity, and who had elevated level of brain injury biomarkers that could be neurofilaments, that could be neuron-specific enolase or progranulin, also had like poor long-term outcomes. And in the same way, it was reported in the literature that if immunotherapy, or at least a good one, is initiated earlier in the treatment course, patient may have a better outcome that was associated with reduced duration of mechanical ventilation for the ICU stay, hospital stay, etc. Nonetheless, we still have heterogeneity in the response to immunotherapy, and most of the results we got were on retrospective data. So we actually wondered whether it's possible to follow the biological markers over time and to serve like as surrogate markers for the efficacy of the immunotherapy. So Anna Maria sent me some slides about what we know actually from animal models. And notably, what do we know about the impact of therapies like anakinra or tocilizumab on the blood or markers. So this is a study that was published in 2019, where some rats were treated with anakinra. And what they found is that the rats who received anakinra actually had a reduced risk of developing seizures than the rats who did not receive it. And biologically, it was associated with a reduction of the HMG B1 level in the blood. So anakinra was associated with a normalization of the biomarker level. But two other studies, and on the left, it was on the pilocarpine model of epilepsy in 2020. And in this study, the administration of anakinra to the animals did not induce any change in the expression of IL-1 beta or TNF alpha. So it doesn't seem to be consistent over studies. And in the electrical status epilepticus model, they found that using antioxidants was able to also reduce the synthesis of HMG B1. In patients, so I did a look at the literature, and I actually found 16 studies that reported the effect of anakinra, tocilizumab, or ITDEX on cytokine levels. And they summarize the result from 26 patients in CSF and 27 in the serum. And I just put some example here to show you the heterogeneity of the results. And if we just look at the anakinra example, the first study in 2016 say that all the CSF cytokines were normalized when anakinra was administered. But in the blood in 2020, there was no clear effect. And in 2022, they said everything is normalized again. So that change over time, that change of a study, and this is the same thing for anakinra, tocilizumab, or ITDEX. And one thing that was interesting also for tocilizumab is the distinction between the CSF and the blood, where IL-6 level seems to decrease in the CSF but increase in the blood. So I had a look at the data we have from the biorepository. And so because each patient has a different schema of immunotherapy, it was difficult to use all of them. So we just divided the treatment into 3 treatment periods, what we did for the complete blood count study. So there is the period NT, so before any immunotherapy. You have the first line after the administration of steroid, IVIG, or PLEX, and before a second line. And a second line after the administration of a second line that could be anakinra, toci, ITDEX, Ritux, cyclophosphamide, or JAK-STAT inhibitors. And so we do have 8 patients with CSF collected during different treatment periods, with a median of like 3 days for the sample first line after the treatment initiation, and around 30 days after the second line. And for the serum, we do have 22 patients with serum collected at different time points, and the delay regarding the treatment initiation is almost the same than what we had in the CSF. So what I would like to highlight here is, so you have on the left the no treatment, and in the middle the first line, and on the right the second line. And we can see a trend toward a normalization and decrease of pro-inflammatory cytokines after the initiation of the immunotherapy. And the flowchart the flowchart on the right gave you the evolution of the fold change if you use a first-line immunotherapy, so this is a red point, or a second-line immunotherapy, it's a green point. And we can see that, for example, for IL-6 and IL-8, when we move toward the second line, the normalization is much more important. So this was just on the 8 patients with sample collected at several time points. But if we put all the samples together, the 109 patients with CSF collected, we have almost like the same result with a significant decrease in IL-8, CCL2, and GCSF post-immunotherapy, but an increase in IL-4. And on the right, you have the time of sample collection after status epilepticus onset. So it's difficult to make some conclusion, but as you can see, we are covering a large window of time. In the serum and the contrast, we do not see any differences when we have patients with multiple time points, that's 22. So no clear effect of the immunotherapy and the cytokine levels. And this is the same thing if you look at the 158 patients with samples collected. So for neurofilament, these are the data from Stefano Meliti, and what I found in the paper recently submitted is an increase over time for the neurofilament, either in serum on the left or on CSF in the middle. And if we try to look at the impact of immunotherapy, there is like a trend toward an increase after immunotherapy, but I think it's just because, of course, when the immunotherapy started, it's later in the disease course. So I don't think it's a true effect. But what is important for neurofilament is that we do have an increase after the status resolution. And it was highlighted in this case where the status ended at the end of the purple bar and you had the peak a few days later. So we need to follow longitudinally this biomarker. So nonetheless, to be able to follow markers over time, we currently have some limitations. So we have an heterogeneity in the time of sample collection. We have an heterogeneity in the treatment that have been used, when the treatment has started, when the samples are collected regarding immunotherapy. And so we wondered whether we can leverage like existing research and new resources, taking advantage perhaps of Picori and Harrison and the currently different biorepository for Norse and FIRES, and making sure that in the future we may request paired sample pre-immunotherapy and post-immunotherapy, and with some time points that we suggested. So basically, the three questions, and I will end with this slide, that the 3 points I would like to discuss with you today is what are the optimal timing of biospecimen collection? And so we made a suggestion with Stefano and Anna Maria to collect the samples after immunotherapy, first 2 weeks after, and for a second point, 4 to 6 weeks after the second line immunotherapy. But perhaps we can also discuss collecting the samples more based on clinical improvement or EEG improvement to be able to have some correlation, or like when MRIs are performed, notably for neurofilament. So we are open to discussion, and also we will be pleased to have your opinion about what sampling strategy is appropriate when we are not using a second-line immunotherapy. So of course, it's not for Picori, but we do have some patients who just receive a first line, and it's not always easy to know when we collect sample after first line, and specifically if it's the same schema, if it's IVIG or if it's Plex. And sometimes it's not possible, we know, to collect samples longitudinally. So we also open like the possibility to monitor some biomarkers that are done clinically, like the CBC or the CRP or PCT, to get higher number of data. Thank you, and I offer Stefano and Anna Maria to join me for the question.
Hi, I had a question, especially as we are embarking on developing our registry. Congratulations on the work you're doing. This is really exciting, and I think it's going to really lead to improved clinical care and outcomes and all of that. How are you standardizing your collection of samples and processing at all of the different sites? Because I think that's going to be one of the challenges that we all face, is making sure we're processing, collecting in a similar way, so that way we can contribute to these studies. Thank you.
Yeah. So for the collection, if you mean time point, so we are basically we work with the enrollment time point. So when the patient is enrolled, we try to collect sample as soon as possible. And for the processing, we are following the guidelines we published in 2023. So notably for cytokines, we are requesting to have the sample centrifuge within 2 hours after collection to make sure that there is no delay that can falsely increase some cytokine in the serum or decrease in the CSF. So we have a flow chart that we request for all patients enrolled in the study. And if the time point is not correct on the flow chart, basically we cannot interpret the results.
So it's Tennille from Western. Something I've used in some of my studies in Canada that we're allowed to do for the early samples, like pre-immunotherapy, if it helps, is a deferred consent model, where we're allowed to draw blood before we get consent. If the family doesn't consent, then we dispose of the sample. I don't know if that's something worth building into the biorepository in general.
Yeah, I do the same in Paris. Actually.
Yeah.
So specifically for the CSF, we collect all the CSF, even if it's pre-consent. And if we don't get the consent, we destroy the CSF. I don't know if in Italy what you are doing.
We do the same, and yeah, we do the same basically. Yes.
Yeah, in the US, we're not permitted to do that. But if there's extra blood left over from their blood draw and still available, we can use that. And if people are getting a lumbar puncture and we're still trying to reach the family or something, we'll ask them to at least freeze it and then we'll try and get consent. But we can't tell them to take extra fluid. That's not allowed.
No, I would like just to raise a point for consideration. I think that the timing of biospecimen collection is very critical after the patient's enrollment, so to say, and it's difficult to establish which is the best time point. I wonder whether we should also consider the variability in the patient's response to the treatment, and rather than fixing time points, to rely more upon the, the clinical response to treatment and collect samples before the initiation of immunotherapy. And when we see a sign of response, there is no sign of response, to fix a time frame beyond which we shouldn't go. I don't know, I think it's important to think about that rather than fixing time points for all the patients, assuming that everyone behaves the same. And also considering that we are probably looking at not symptomatic treatments in the strict sense, because we are modifying a potential pathological substrate. Therefore, it may take time before the pharmacodynamic biomarker is modified. I don't know. We should think about that.
I have a question on the value of the absolute value post-immunotherapy and some of these markers versus intra-subject change. Because for me, the problem is not so much the subsequent biospecimen measurement, because by then these patients are enrolled in our studies and most of the time they're in the hospital and it's okay to get a second tube. I think the problem, and I'm curious to see what's the missing samples in your studies so far, but I think the problem is very often, at least for example, in my center, patients get shipped from other hospitals. They've already gotten steroids, IVIG, and they're getting shipped because they're not better. And so that's, I think, the problem. And I wonder if it's an actual problem. Maybe you don't need to compare to pre-immunotherapy, but I think that would be an important question to answer.
Yeah, I totally agree. And for the problem with the first line and pre-immunotherapy, I think we have that in all centers. And that explains why we have like 109 patients with CSF collected, but just 8 with CSF collected at multiple time points. And it's because most of the time, like the first CSF is collected after the first line immunotherapy, and something almost for the blood. So we can increase networks and try to get sample quickly, but it's not, yeah, I agree. It's a question.
There's a question from Marios Kaliakatsos, and his comment is, I think we should encourage much earlier the use of IT decks, and this would probably increase the timelines of CSF and serum samples.
Yeah, I agree. I agree, yes.
Just one comment I was going to make is maybe have a subset of patients where you do really frequent samples to help figure this out. Just do weekly samples and a subset. Serum, you can do that fairly easily to help figure out the best time. Okay. Next, we have Claude Steriata and Deepak Saxena from NYU talking about gut microbiome. Or just Claude.
Thanks for inviting me to present to you today. I just have 2 slides or 3 on why it is that I'm presenting this, but really I want the bulk of this presentation to really be your feedback to us. So just quickly about the rationale behind this. Many of you participated in the event we had on Wednesday on gut microbiome and seizures, so this will feel somewhat repetitive for some of you, but essentially the idea is that gut dysbiosis is present in epilepsy. It's also present across the spectrum of many systemic inflammatory conditions, and the gut microbiome interacts with the immune system. And there are multiple mechanisms through which changes in the gut microbiome can result in changes in cytokine and neuronal hyperexcitability. There's also a good clinical observation with the effectiveness of the ketogenic diet, which works through the gut microbiome to support this idea. And so our hypothesis is that the gut microbiome changes in patients with Norse. We had a nice discussion on Wednesday about whether there's perhaps a different host microbiome prior to Norse starting, or whether this is a result of some of the early effects of seizures, which then lead to a vicious cycle of difficult to control seizures, which then reinforces the neuroinflammatory response. And so really what we're trying to do here is find new targets for interventions that may be more effective. Larry already talked to you today about some preliminary work that we've done and was published earlier this year. And I won't go into details, but essentially we did find that there were changes in gut bacteria, but also interestingly fungi in patients with status epilepticus and Norse compared to chronic epilepsy controls. This was a study that we did with samples from the Norse consortium. So thanks to everybody in the room, many of whom contributed samples to this. And we compared to disease controls. And what was interesting here, among many things, is that we found that certain gut microbes correlate with cytokines that we know are upregulated in Norse. And so it may be that these gut microbes play a role in modulating the immune response. And the other thing that we found was that over time, the gut microbiome does change. If you look at, and then we were just talking about timing. So the way that we did it in this study is that we defined 2 time points. T1 was during status up to 3 days after status resolution. We chose 3 days because we're looking at stool samples and gut motility is different in critically ill patients. And then we looked at T2, which was defined as 4 days after status epilepticus resolution. We found that you can see here T1 during status and T2 after status. It's really more after status that we were seeing changes in the gut microbiome in Norse compared to status epilepticus controls, and that may be due to a number of factors, including the way in which we treat these patients. And so the questions that we're now asking is, are these changes just bystanders of some of the treatments that we're using in these patients, or are those changes actually central to the effectiveness of some of the therapies and maybe targets for changes to their treatment? So what we would like to do is leverage the large-scale studies that are now funded in Norse. And so we want to leverage the PCORI and Arisen study to perform large-scale microbiome metabolomic studies to look at the effect of the gut microbiome and metabolomics and cytokines. And so this is what we're proposing, and we're open to your feedback on whether this is too intensive, maybe not intensive enough, in terms of specimen collection. So here we would be proposing to do blood, CSF, and stool day one being the day that you're enrolling the patient, identifying them, and as part of the PCORI study, that's before they've gotten tocilizumab and anakinra. And so the CSF is part of the lumbar puncture that they're already getting. So hopefully that CSF is already in the lab or getting obtained around the time of the consent. Another sample on day 2. And then we would be getting serial samples at day 3, 4, day 8, day 28 at the time of discharge and at follow-up. And then at the same time, we'd be collecting a number of clinical covariates, which are important for gut microbiome, including immunotherapy, sepsis, feeding, ketogenic diet, et cetera. So this is what we would be proposing to do. And so these are our 3 aims. And again, I'm curious to hear if you think those are aims that are worth asking and questions that are worth asking and possible to answer. So first, we just want to characterize the changes in gut microbiota, metabolomics, and cytokine over the course of the disease. And really what we want to do is look at Norse, but also disease control populations. And we want to do refractory status epilepticus, but also a critically ill population. The question we want to ask to the group is, do you think it needs to be a neurologically critically ill population like stroke TBI, or just a generally medically critically ill population like patients admitted to the medical ICU with sepsis? And the idea is that we might find similar things in larger groups of patients, that this is a dynamic process that changes in a different way over the course of the disease. And we want to see if early gut microbiota is going to predict how patients do in the longer term. We have some preliminary data based on these, 15, 17 N of samples where we found that gut microbiota early could correlate with mortality in both Norse and status epilepticus patients. And so we have a number of techniques that we want to use to try to model this as a biomarker. And then our aim 3 is to try to see how pre-treatment samples and post-treatment samples, and we'll see what timing would be the best, can predict response to each of those immunotherapies and see if we can identify maybe patients. Some patients are more likely to respond to one or the other depending on their profile. And so these are the questions. How do we address the heterogeneity of the timing of diagnosis and biospecimen, the nature of the treatments? Like we discussed, many of them are not immunotherapy naive. They may be pre-anakinra tocilizumab, but many of them will have been on steroids IVIG or post-plex. How to match our disease control cohorts to the Norse group, to what degree, what are the factors that are really crucial? What we're looking for in matching a critically ill population. Do they need to be neurologically ill or just medically ill? And how we were thinking about using the Apache score. And I just want to highlight something. I want to be very optimistic and enthusiastic, but we have to look at the data. For this study that I just presented to you, it took us 4 years to get 10 sites to give us biospecimens on 15 people. And so, hopefully with more resources and now with this study and the Arisen study, there's like a big momentum, and I hope that it would go a lot better. But I also want to be realistic, and I want to understand what people feel are the barriers to enrolling. I would have thought that stool would be something that is so easy to contribute, but many sites were not doing that, and I want to understand why that is and what you think maybe we could do as a central site coordinating the study if we hopefully get funded to help US sites get this done.
I'll just make one comment. I think that you still need consent. So you still have to enroll and consent patients in something to get the sample. So that's why I think it's crucial to grab onto these trials where they're already going to be.
Right. Yeah.
It'd be
There's
very
already
easy to just add on a stool collection.
But I mean, not everybody that was in the Norse study contributed stool biospecimens. I mean, everybody said they wanted to do it, but just I'm not saying anything went wrong, but I want to understand if some sites were not able to do that, why that is, and maybe what you think we can do on our end.
I think that's mostly because there were not research assistants dedicated to the studies. But now we will have that.
Right. Okay.
Picori for sure, Arisen.
Yeah. Okay.
But that's the low-hanging fruit is to get into the Arisen group also.
Yes.
Hi, this is Olga Jashenko. I was just going to point out that in our center, even extra urine collection, extra cath, which is outside of a clinical indications, is a problem because our research coordinators are stuck with a protocol. So anything beyond typical care for patient is violation from the protocol for them. So we're running into these issues of extra, you can't take it from the bag, for example. For the urine, you need a clean gas, and that constitutes a problem for some sites.
Yeah. But in the Picori study, there's going to be an optional biospecimen, right? So it wouldn't be a separate consent,
right?
Correct?
So I think with Picori, it may be overcome this way, but so far with the registry, it's been an issue.
Okay.
I'll try to give you quick answers to some of your questions. Yeah, so matching Norse patient is extremely difficult. These are very different from most of the status epilepticus patients that you see. So it's unlikely you will find good matches. So I would not try too much to match them. Okay. Maybe just focus on refractory status epilepticus and not bother too much about age and things like that. I would tend to, if you want a control group, I would still mostly focused on neuro ICU patients, not your general ICU patients.
Yeah.
Mostly because of the types of antibiotics that these patients will receive. You don't want, you don't want patient with acute GI issues
Yeah.
because they get very different treatments, right? So I would focus on neuro. The Apache score is not a good way to match for neuro patients because mostly the GCS will drive everything
Yeah.
in terms of matching. So just matching for consciousness level and refractoriness of status epilepticus, I think would be.
So what would you use?
TBI, massive strokes, Cerberax. Yeah.
And you wouldn't try to match them. You would just say they're also critically ill. So
I guess
that's
the
enough.
best
Level. Oh, that okay.
I guess I would do Norse refractory status epilepticus and acute brain injury without status epilepticus.
Okay.
And
That's helpful.
yeah, not much too much.
Sounds good. Thank you. Yeah.
I'll just offer I can talk to you on the side. I have some data looking that I haven't processed yet, looking at status epilepticus versus TBI and sepsis controls. Because part of the issue is it depends on, like, if you're incorporating with the other studies, it depends on what kind of brain injury you're looking at, what kind of inflammation
Right.
for your control. So I'd be happy to
Yeah,
see
yeah,
that
yeah.
slide.
Okay. That's great. Thank you. Thanks so much.
Thank you very much.
Dr. Norris, there's a question. Dr. Hirsch, there's a question in the chat.
Okay.
This is from Dr. Yushin. How are you going to control for the effects of antibiotics?
So in the study that we published this year, the overwhelming majority of both refractory status, actually they were not all, both status and Norse were on antibiotics, and there's this Maslin analysis you can do to account for covariates and microbiome, and there were very minimal effects. So we are collecting this data. But what we found is that most of these patients are on antibiotics because at some point they spike a fever and at some point they get put on it. And we found that they were most of the time on similar antibiotics for similar lengths of time. So we'll collect it. But I was more worried about this initially than after we looked at the data.
I think that's, hi, I'm just going to, you can hear me, right? So your control group, basically that's maybe a problem because if you're using TBI or stroke patients, you need to, we'll just need to make sure that their antibiotics exposure is the same. Because, a lot of times these kids, the Norse patients or RSEs, we assume that it's some kind of, infectious, right? So they're on empiric antimicrobial for 48 hours right up front versus somebody with TBI or stroke, they may not necessarily be on antibiotics. So
That's helpful. Thank you.
All right, thanks. We're going to have to move on. Next, we have Dr. Tarashenko. She'll let you know what she's talking about.
Okay, that says this. Good afternoon, guys. So it's going to be a switching of the gears a little bit. So since CPCORI was awarded, we all on a medical scientific board are thinking hard how we can leverage the specimens and other data collected. So my lab has been focused on immune mechanisms of seizures. Particularly, we were focused on anti-NMDA receptor encephalitis seizures, but we believe that this can be expanded to not only NMDA positive Norse, but also potentially cryptogenic Norse. You can see that diagram on the right-hand side from famous Anna Maria's review. And while she wrote it in reference to idiopathic run-of-the-mill epilepsy, we believe that this pathway also has a relevance for autoimmune seizures, and we think that antibodies potentially trigger this. Is there a password? Okay. Signaling through the IL-1 receptor and toll-like receptors, and it goes through this MID88 protein, which is a major adapter protein in this pathway leading to through the IRAX to NF-kappa B, and that changes the transcription and genes associated with that and may sustain both seizures and actually memory loss in encephalitis and possibly in Norse as well. So why MID88? Because we know that it's been looked at in terms of idiopathic epilepsy. So there was upregulation in epileptic brains from animals and humans. And also that this pathway is very relevant for other immunology of cancer, for example, immunology of rheumatoid disorders, and et cetera. So we have high hopes on focusing on this pathway and potentially looking at the mechanisms of seizure resistance, particularly resistance to immunotherapies. Just some background from my lab. What we've done is we use mice that are deficient in MID88 protein and infuse them in our model with anti-MID receptor antibodies. And in contrast to wild-type mice, these mice do not develop seizures. It's shown here. This is a wild-type mice. They also don't have memory impairment shown here. They have normal discrimination between novel and familiar object. So they behave similarly to wild-type mice infused with control antibodies. We also looked at the immune profile of these mice, and very interestingly, among all other immune mediators that are relevant for epilepsy, only CCL2 was sort of abolished in those mice. This is a wild-type change in response to antibodies, and this is MID88 knockout mice. So that was very interesting because CCL2 came in light after the recent papers that came out of our registry and orally published recently a paper showing that there is a specific pattern of CCL2 activation in patients who are particularly resistant to treatment. So that kind of correlated well with our finding of increased hippocampal CCL2 and abolishment with removal of MID88. So we thought that this aberrant signaling in this pathway may contribute to seizure refractoriness. And refractoriness, I mean refractoriness to immunotherapies. So what we propose to do, and this is partially was submitted as a part of my grant that I just went to the NIH, but potentially leveraging the supply of biospecimens, serum and CSF coming from PCORI trial and other relevant multicenter studies to use cell cultures of human-derived cell cultures of astrocytes and microglia and expose them to those specimens from patients with Norse, and then potentially even look at subgroups of patients with antibody-positive Norse versus cryptogenic, and study how this pathway is working in those conditions, in those two different subgroups of patients, refractory versus responsive to immunotherapy, and then also try to inhibit the signaling with some inhibitors of MID88 and downstream protein IRAK4. Those agents are available on the market. Some of them are being used for actually treatment of malignant tumors. So they've been out all the way out to clinical trials. And then we predict that obviously the signaling will be enhanced, and then inhibition of this pathway will reduce signaling more in resistant patient samples compared to responsive. So if this is successful, we can potentially identify what is behind the resistance to immunotherapy. Is this aberrant activation of this pathway? And then uncover some additional targets, like those two proteins can be additional targets for the therapies that already exist for other indications and available on the market. One step further, and we just team up with one of the collaborators at our center, is to use human organoids. And those organoids are done from patients, actually, from peripheral monocytes, from peripheral blood cells. And they can be obtained from either normal subjects or from patients with Norse, and then tested kind of in a similar paradigm. So this is that, loop back to the bedside. And this is just illustration of different markers that are present in those organelles. So there are neurons, and there are microglia and astrocytes. And you can, as I said, go to a specific patient and make the organelle sort of coming from that individual patient and study subgroups. So that's all I have. As far as what sample timing would be ideal is probably before the treatment, because that's what makes sense. So prior to initiation of immunotherapy. But I have to say that the reviewers on the grant were very tuned into the timing of collection, because I was particularly drilled on how do you compensate for variability of samples due to immunotherapy. So I was asked to specifically put the timing of immunotherapy in the revision. So it is a critical point. But we do have to have some specimens before the treatment.
I'll ask one. Are there existing medications that are anti-MRD88?
Yes, those two. So one of the question, okay, the people here on Zoom, whether the available treatments, yes, some of them are in clinical trials for the cancer indications. Yes, yes. At least for one of those two targets, you can get them.
Those are the kind of people you could potentially ask for money to fund biosampling and yeah, but that for all of you, if there's a pathway you're interested in and there's a drug out there that might affect it, those companies might be helpful in funding biosampling from the existing trial patients. So it's a great opportunity to collaborate with them. Nora.
I have a comment from one of the parents for Claude. She mentions that when her son was in induced coma, he didn't produce many bowel movements. And then she reminds me, neither did mine. So that might be an answer to why you're not getting many.
Okay, so the next step is just questions in general for anyone, announcements, comments, or anything for another 5 minutes or so, and then we'll let people just talk to each other live, including questions on Zoom. So let me stop sharing. Eyal, I think you wanted to make an announcement or reminder. Are you on?
Yes, I am. Thank you. Can everybody hear me?
Yes.
Just want to remind everybody that we do have a monthly international case conference for both pediatric and adult patients. It's for medical professionals only, for both FIRES and Norse. It's jointly run by both our institution, Texas Children's, and GOSH. So Mario's who's also on Zoom. You can contact either of us. We do have utilized the Norse Institute for advertising at times, but also have our own robust kind of listserv. We often have medical professionals for over 9 countries and at times 30 individuals. I think our motto is we're all a community of learners. And our next case conference is actually this Friday, at 9 o'clock Eastern time, which is usually, I think, about 2 p.m. in London. So please join us. And I think my email is in the Zoom for those of you that are on Zoom to reach out to us to get added or tell us about cases. Thank you.
Hi. I had a question about the enrollment.
Suki, tell them who you are.
Okay. This is Sukika from Children's Nebraska. I had a question about enrollment for our combat study. I think you mentioned that we want to enroll refractory status, not necessarily supra-refractory status. And I noticed that in census, in fact, only 7% of the patients who were enrolled in that census study had Norse and FIRES. And so I'm wondering, are we really going to be focused on refractory status epileptic cases or super refractory, and at the time of enrollment, if they stopped having continuous seizures, will they still be qualified to try tocilizumab versus anakinra? The reason why I ask is that even non-super refractory, just a refractory status that goes on for 24 hours, for example, and then stop, there will be inflammation, and I think they could potentially benefit from immunomodulation. But for our purposes, I think the enrollment number of patients who will be enrolled or who will be qualified will be vastly different if we were to enroll refractory status epilepticus.
Yeah, so for the PCORI trial, you're supposed to have failed first-line immunotherapy and still in status at the time of enrollment. So it doesn't necessarily mean you had to get anesthetics during that time to qualify as super refractory, but the vast majority will be super refractory and still seizing at the time of randomization. I think it's a great point, though. Maybe even people who are not in status anymore should be randomized, but that's currently not what we're studying in the PCORI trial. But the SENS registry, where's Nicholas? I think it's going to include all those. In the people who couldn't identify them, it's going to include all of them. So we'll be able to compare them, and they're fantastic controls. So, did I get that right? Any other comments, questions, including from Zoom land? All right. Well, we left you 8 minutes to talk to each other and network before you run off to your next section, or you can stay around longer. But thank you, everyone, for joining. This was super helpful.